Hello everyone and welcome to your anaphylaxis and emergency medical conditions update. I'm sure everyone's been thoroughly looking forward to this, so we will crack on. So today we'll run through what anaphylaxis is, causes, types of reaction, treatments, and then we'll just run through 3 types of other emergency medical conditions that we see in the school. So what is anaphylaxis? Anaphylaxis is basically a severe systemic allergic reaction, and it's where the body attacks a substance which it thinks is a threat, and this causes a huge chemical release, one of these chemicals being histamine. And this affects the whole body within minutes of exposure, and it can take seconds or several hours for you then to see the effects of this and the types of reaction that the child is having. So the one thing that stops the production of these chemicals and in turn reduces and reverses the type of reaction that they're having is adrenaline. Common causes of anaphylaxis, there's 14 known foods that are under the FSA as food allergens. You've also got things like drug allergies, wasp and bee sting allergies and latex. So most common in children is that of peanuts. 1 in 70 children have a peanut allergy, and about 25% of these will go on to have tree nut allergies. Other common ones in children, milk and egg. Egg, for example, is it cooked egg or raw egg that children are allergic to? Cooked egg is the likes of in a cake. Raw egg is not pure raw egg, but actually like a runny egg with soldiers. Some children are allergic to one and not the other. More commonly being seen is that of kiwi allergies, predominantly in under 16, so one that we've got to be mindful of. So exercise-induced anaphylaxis is a very rare type of anaphylaxis. Sounds like something they'd use to get out of games, but it's actually an anaphylaxis that occurs after exercise, and it's usually in line with a food, non-steroidal anti-inflammatory drugs being taken, or cold weather conditions. So they may not be allergic to the food generally, but in conjunction with exercise they then go on to have an anaphylaxis. And thankfully we've got no pupils with this at the moment, but we must be aware of it because things are ever changing. So best way to avoid an anaphylaxis is to avoid the allergen. If you've got a child in your form or your class that you know has allergies, knowing what they are, knowing how they react, knowing where they keep their pens is really important. So being aware of the allergy and then risk assessing the situation that you're putting that child in. So for example, special occasions, at Christmas time, allergens are floating about in the form of gifts that children might bring in, different cards they might make, things like that. School trips, these children are completely normal by the fact they have a severe allergy, so we don't want them to miss out on things like school trips, which is why we do a lot of planning with the co-curricular team and also parents in order to ensure that these children don't miss out but they're as safe as possible. Within the school, cookery lessons, science experiments, arts and crafts, being mindful of what we're using, what we're cooking, what we're doing in these lessons. And for example, if they're doing craft work and they're using cereal boxes, if it's crunchy nut cornflakes and there's remnants of that, you could send the child into anaphylaxis. Which sounds quite extreme, but is a real possibility. School pets. I know there was a puppy coming into the junior school pre-COVID, but also things like bird tables, and it's not so much the birds, but when the kids are rifling through what's on the bird tables, and that might be seeds, nuts, that's when we've got to be mindful. So the way to stop an anaphylaxis is through the use of an adrenaline auto-injector. And adrenaline is a life-saving drug that acts within seconds on the body. And the most important thing is that it's given promptly, because any kind of delay can result in sudden deterioration and also death. I should have warned you of how light-hearted this presentation. Adrenaline acts on the body by essentially doing 4 things. So it reverses the swelling that's caused by an anaphylaxis, and that involves swelling of the mouth and tongue, but also the small airways. And this then in turn relieves the asthma symptoms that we see in an anaphylaxis. The other thing that happens in an anaphylaxis is that the blood vessels leak fluid, and this causes the blood pressure to then drop. So what we essentially do with the adrenaline is to constrict those blood vessels, which brings the blood pressure up and stimulates the heartbeats. in an anaphylaxis, adrenaline takes seconds to work, whereas antihistamines take up to 15 minutes, which is too long in a situation like this. And what we often see is people think that children in an anaphylaxis are actually having an asthma attack. But what we need to be mindful of is that adrenaline will relieve asthma symptoms, whereas an inhaler will not relieve anaphylaxis. So if we are in any doubt, adrenaline is our line of action. So mild reactions can vary in terms of how they present. So this little girl is having a mild reaction. So facial swelling of the eyes and lips, they can come out in rashes and hives, which we've got some pictures of next. Swollen extremities, so hands and feet, and the ear, the creases of the ear, you'll lose those features. Children might complain that their mouth or throat is itchy or burning, just real irritation of both. Some children will have diarrhea and vomiting, some will just say they feel sick, and also like a lightheadedness, so kind of feeling a bit dizzy and faint. And these are some pictures, so top two photos of the types of rashes we get, so the hives on the left and the more urticarial rash on the right. It's like a stinging nettle rash, and some children will get this widespread, some in just patches. If it's only a small rash, it doesn't mean that it can't go on to become an anaphylaxis. Bottom two photos, unfortunately my head is covering the right hand one, but if you can just see that she's got her swollen lips, but she's also lost colour in her lips and become a bit blue around the eye sockets, and our little boy on the left is quite swollen in his lips. So first line of treatment for minor reactions is antihistamines and inhalers. Each child known to us will have an individual care plan, and this will document how much antihistamine to give and or an inhaler if they are prescribed one. However, if the symptoms are looking like they are worsening, you give adrenaline before anything. Scrap the antihistamine and the inhaler, so just to be mindful of that. Contact us in the medical centre. If it's looking more severe, please ring 999 first. And sit the child down, or lie them down even better, so that they don't faint and hurt themselves. If they're sounding slightly wheezy, the best thing is to lie them or sit them and actually get them to either sit straight or raise their head and shoulders slightly if they're on the ground. And that just helps to open the airways. So anything that you give, anything you do, just record the time that you're doing this. And there is always to be one person that stays with the child throughout, and someone else can be contacting parents to get them to attend. So severe reactions, you can have all of the minor reaction symptoms, but also difficulty in breathing, so wheezing, stridor, cough. Stridor is like a high-pitched whistling sound. Swollen tongue, which will lead to difficulty in swallowing. Racing pulse, if you're not comfortable taking a pulse, even just resting your hand on their chest will tell you how fast their heart is going. They might become pale, blue lips, blue eye sockets like the little one we saw, bit drowsy. Impending sense of doom, don't expect anyone to give you those exact words, but they'll be frightened, they'll be scared. Some younger children will just go completely quiet in kind of a sense of shock. So, treatment of a severe reaction. Following the management plan as per the minor reaction, essentially you want to lie the child down. Don't move the child, don't try and sit them up, don't try and stand them up. Like this lovely lady is demonstrating, you can elevate their legs slightly to help with the blood pressure, but essentially you can kill someone who is having an anaphylactic reaction by standing them up too quickly because of the blood pressure drop. I told you this was light-hearted. So one person to stay with the child at all times, whilst the other goes to get the adrenaline auto-injector. Older boys will have the pen on them, so from year 6 upwards, in a belt round their waist like a running belt, or in their blazer or bag. Junior school children below year 6 will have their pens in the school office. We have spare pens for every child who's got an anaphylaxis here in the medical centre, and there's also the spare auto injectors around the school which we'll go into. That same person or another person is to call us for help, but also 999. In terms of positioning, if the pupil is wheezy, you can raise their head and shoulders slightly. Make sure it's only slightly. You don't want to occlude their airway by pushing their head too far up. give the auto-injector. That is your priority, and we'll go through how to give that. And call 999. Make sure you tell them that the child is in anaphylaxis, not an allergic reaction, and that you've given adrenaline. Someone else can be contacting the parent whilst all this is going on, and essentially you wait for the ambulance. You do not move the child, you keep them in that position. If there is no improvement or if there is deterioration, at 5 minutes you give a second dose of adrenaline. You do not wait for the ambulance. Adrenaline is a really safe drug. I know my head is covering this big red sign. Adrenaline is a really safe drug. You cannot harm someone by giving them adrenaline, but if they need adrenaline and you do not give it, then you harm them severely. So if in doubt, give adrenaline. A couple of things that increase the risk of a severe reaction. A child already having poorly controlled asthma will make an anaphylaxis far worse for them. If they've already got tight and narrow airways, and then to put an anaphylaxis on top is going to be a poor outcome. Depending on how much allergen has been taken, a few drops compared to a whole cup of milk is going to give you a very different picture. Infection, where the body is already under stress and already struggling, to then have that level of reaction on top is going to be a struggle. If the child has hay fever or aeroallergens, you need to be mindful of that in terms of the breathing also. Any kind of activities that can actually put a pressure and a strain on the body, so exercise, heat, emotional stress, alcohol, the body is already on the back foot, and then to throw anaphylaxis at it is a huge thing. There's two main adrenaline auto-injectors. First one being the EpiPen. At 30 kilos, you go to an adult dose, which is 0.3 milligrams. Anyone under 30 kilos, it's a 0.15 milligrams. 0.15 is the child dose in the green vial. 18-month shelf life on these pens. You're going to take off the blue cap. You can do whatever you like with that. Pull off the blue cap, you're going to hold the pen at a 90-degree angle to the thigh. From a few centimetres away, you're going to jab it into the thigh, hold for 3 seconds, counting slowly. In a panic, 3 seconds goes very slowly. Count to 3, withdraw. The needle sheath will cover the needle to protect you from needle stick injuries, and massage the site for 10 seconds. This pen can then be given to the paramedics and they will dispose of it for you. Be very, very careful. In a panic, people often will take off the blue cap, they'll turn it round, they'll jab that into the thigh and get a lovely needle into the thumb. No adrenaline for the child, lots of adrenaline for the person that's already got too much adrenaline running around them. So the second type of pen is a Jext pen. Similar principle, same doses, same kilos that it changes. This one has a 24-month shelf life. Different colours this time, so the rhyme is less impressive. Yellow to sky, black to thigh, if that's easier. Take the yellow cap off, dispose of that wherever you fancy. With this pen, you're going to place the black end to the thigh. So no swinging of this one. You push with force and you hold for 10 seconds. So in both of them you hear that click and you start your counting. Count to 10, pull off, and the sheath will cover the needle. That can then be disposed of by the paramedics, and then you massage for 10 seconds to get the adrenaline going around the body. So it's that click that you're listening for in both pens. And so where are you injecting these pens? You're going to go into the upper outer quadrant of the thigh, the nice squidgy bit, through any clothing that is there, preferably one layer if possible, but do not faff trying to get clothing off. So these are our allergy action plans. So they'll have a picture of the child, their date of birth, emergency contact details to contact parents, how to give their specific pen, whether it be a Jext or an EpiPen. We don't have Emerade anymore. And then it tells you what a mild reaction looks like and what a severe reaction looks like. It reminds you about keeping them flat. It reminds you of what to do and what to say. It even spells out how to say anaphylaxis, which is helpful for us all, to be fair. Some of the reasons why people have failed to give adrenaline auto-injectors because they felt it wasn't necessary, they weren't sure if they were in anaphylaxis, they'd already called an ambulance, so just thought they'd wait until they arrive. If the device isn't available or they're not sure of how to use it. Unfortunately, the aforementioned reasons for lack of pen administration came through in the case of Karambir Chima. He was a 13-year-old little boy who had an anaphylactic reaction to dairy. He was a known anaphylactic pupil. He had skin contact with cheese after a peer threw some cheese at his neck at lunchtime. He developed a rash, which the teacher didn't really pick up on as a part of his anaphylaxis. He was sent unaccompanied to the office where they too thought he was just having some kind of localised reaction. He then went on to struggle to breathe and told them that he felt like he was going to die, at which point they gave him an EpiPen. This was 10 minutes post-reaction onset. The EpiPen was out of date. There was no second pen. Unfortunately, whoever rang 999 said that he was having an allergic reaction as opposed to an anaphylaxis, which meant they did not come for 30 minutes, and on their arrival he was already in full-blown cardiac arrest. He went on to be intubated and placed in ICU, intensive care, at the hospital, where he died 10 days later. And the combination of factors that were found in this case obviously then led to a great deal of learning and changes in schools. And that's when the Department of Health brought in this new legislation, which basically means we can have the auto-injectors around the school. They're in the school offices, sports club, boathouse, and it's for children who already have parental consent for a spare auto-injector to be given, which is part of their care plan. If their pen is unavailable or not functioning properly, or if you're on to 999 and you have a person, be that a pupil or a person that's around the school, if they're showing signs of anaphylaxis and the call handler asks you to give. So in conclusion, the key principles of good anaphylaxis management: reducing and avoiding allergens and exposure risk, being able to recognise early signs for reaction and calling for help promptly, and then if you find yourself in the situation that a child is having an anaphylactic reaction, following the action plan and calling for help. So that's anaphylaxis done. We'll just very quickly touch on asthma, diabetes and epilepsy, as we have quite a few pupils with all three of these things. So asthma is a condition that affects the small air passages in the lungs, and it's essentially where the muscles around those small air passages get tight due to inflammation and irritation as a result of being in contact with a trigger. And this then in turn causes difficulty in breathing. So you can see the difference between the normal airway, that lovely big hose pipe in the middle, coming through to this tiny little tube that the air needs to get through. So these are some of the triggers for an asthma attack. More commonly in our pupils, things like pollen, dust, pet hair. If they've already got an infection underlying, like a respiratory tract infection where the airways are already swollen and compromised. Strong odours like cleaning fluids, perfumes, environmental, cold weathered conditions. If they're exercising and pushing themselves to the limit, the same way that if they get stressed or upset and push themselves to the limit in that sense. Alongside things like secondhand smoke, or if they're smoking themselves, which is not unusual in some older pupils. Gastric reflux, so issues with tummy and things that we add to food. So some of the symptoms of an asthma attack can include coughing, where they're trying to get air in. They'll be short of breath, so they might be panting, they might be heaving their shoulders, you might see sucking in around the throat, under the ribs. Wheezing again, that kind of strange noise that happens when they're breathing in and out. If they complain of tight chest or go quite quiet, and they'll have difficulty in explaining to you because they won't be able to say that many words in one sentence. Some of the younger children will say they've got a tummy ache, which is their way of saying something's not right. In an asthma attack, The main thing is that the person who is there to help stays calm. If you start panicking, everything's going to break down. The child is already panicking because they can't breathe. So nice and calm, sit them up straight like this little girl here. You're going to use the emergency asthma kit. They're in the lunch boxes. They look like lunch boxes, in the same places as that of the auto injectors. So there's disposable spaces at the moment which are like paper cups. Make sure you read how to put that together. That's only because of COVID. We will go back to plastic ones eventually. And like in this photo here, get a good seal around the mouth and nose. And using the blue salbutamol inhaler, you're going to give 1 puff every 30 to 60 seconds, and you're going to do 10 puffs at a time, and then reassess. Contact us in the medical centre so that we can come and assist. But essentially, if there is no improvement after 10 puffs, or they've actually gotten worse, or you're worried at any time, you need to call 999. And if the ambulance is taking longer than 15 minutes, you are going to continue with the 10 puffs. So these are called bursts, and these should help to actually open up the narrowed airways. So that was very brief run through of asthma. So diabetes is a serious lifelong health condition. It's where the amount of sugar in the blood is too high because the body can't use it properly. And if it's left untreated, these high blood sugar levels can actually cause serious ongoing health complications. And there's 2 types of diabetes. So type 1 is more common in our young people. So boys in the college will have type 1 diabetes. And it's essentially where the body attacks and destroys the insulin producing cells. And that means there's no insulin produced, which then in turn allows the blood sugar to rise very quickly in the blood and cause all kinds of issues. Type 2 is more common in older people, though not exclusive to them. And it's essentially where the body either doesn't make enough insulin, or the insulin it does make isn't efficient in doing its job. And so the glucose builds up in the body, in the blood that way. And the emergency that we'll see with these children is that they'll go into a hypoglycemic episode, and that's where there's low blood sugar. And these often have a very fast onset with little warning. These children can feel shaky, they'll start sweating, feel hungry, they might be a bit lethargic, with blurred vision, unable to concentrate and focus, headaches, they might get a bit angry, a bit tearful, and they'll be very pale. They'll look rubbish. We've all had episodes of hypos ourselves where we're hungry and needing our lunch, but for diabetics it's much more serious. So those kind of feelings we've all sensed, that in a more severe setting. So treating a hypo, all children will have their own ways in which they like to treat their hypos. Non-diet drinks, so a fizzy drink with lots of sugar in it, glucose tablets like these Lucozade ones, though most of our children here prefer some kind of sweets or biscuits that have a high sugar content. Pure fruit juice is another option, or glucose gel that they can just squeeze in their mouths. Now, once we've treated the hypo, you then need to give a slower acting carbohydrate such as a sandwich, some fruit, just to keep that level up. Diabetic emergencies, if you find a diabetic unconscious, you need to pop them in the recovery position, call 999 and let them know that the child has diabetes and is unconscious. You need to be saying the trigger words, diabetic, unconscious. Check if they've got their hypo bag on them. We have hypo bags here in the medical centre. Call us, we'll come and assist. And for children that are unconscious, you can give them hypo stop gel. So that goes on the gum, so in between the gum and the mouth. And that's absorbed through the gums to bring the blood sugars up. Do not try and give them anything to eat or drink. Do not put things in their mouth, please. Don't need a child to come to and then choke. Glucagon injections can only be given by a nurse. We can give them if they're unconscious, having a seizure, or if the hypo stop's not done any work. And lastly, we'll run through epilepsy. So types of epilepsy, 2 main types of epilepsy. First one being generalised absences, and this is where for a short period of time the child will lose consciousness. It looks like they're just daydreaming or getting distracted by something in thin air. You don't need to do anything for these children, you just need to reassure them when they come round, so don't assume that they have any idea of what's just gone on. The more commonly known type of epilepsy is that of tonic-clonic seizures, so this is what you'd see on Grey's Anatomy and things. The pupil will lose consciousness, their body will go stiff, and then they'll fall to the ground, and then they start the jerking movements. And these should only last a minute or two, but you're most likely going to see that they'll go blue around the mouth and eye sockets because they're not getting enough oxygen in through their irregular breathing. They may lose bladder control, bowel control, but hopefully after a few minutes they then stop the jerking and start to regain consciousness. With a child that's had a seizure, protect them from injury. A lot of the time someone will have a seizure in the possible worst places. So move everything from around them, cushion their heads so that they're not going to risk a head injury, and put them in the recovery position once they have completely stopped seizing. Make sure you stay with them until they are fully recovered. It can take them quite a long time to actually recover fully. Don't try and restrain them or hold them in place. Don't assume that when they come round they have any idea what's gone on. And also, BLS trained people often want to clear airways, which we tend to do with a finger and get an object out of the mouth. Please don't do that with someone who's seizing. We have had people through A&E who have lost fingers, as a heads up. So, ambulance should be called if this is the person's first seizure, if it's continuing for more than 5 minutes, if one seizure follows the other without consciousness being regained, if there's any injury during the seizure, or if you just feel that the person needs urgent medical attention. Where can you find pupils and their conditions? So on ISAMS they'll have an orange flag next to their name. On My Dulwich, under the health and safety link, you can find all of the pictures for the pupils with anaphylaxis and what they're allergic to. On Evolve, for trips and expeditions, the details will be there. And then in terms of policies, on My Dulwich, under policy and guidance in the medical centre section, you'll be able to see the anaphylaxis, asthma policies, etc. That was a bit of a whistle-stop tour of these emergency medical conditions. If anyone wants to have a go of using the pen so they feel more comfortable, or run through anything, hopefully not everything, anything, just give us a shout and one of us can help with whatever you're worried about. Thank you.